Okay, so I guess this is recording to my local computer. So hopefully it doesn't slow down any bandwidth or anything. So yeah, welcome to our review session. It's just starting now. We are going to just go over any questions or any content that you all have any issues with. More than happy to answer those. So who wants to ask a question first? I'm not guaranteed to have all the answers, but I'll try my best.
I have a question about the lung and chest wall compliance curve.
Okay,
Like I
perfect.
understand compliance, but so for some reason, when I look at that little curve, the whole
Yeah.
FRC 60% VC confuses me.
For sure, yeah. So let me go to that slide, and I believe, and I'll share my screen here. Let me go here, go to share my screen, share screen. All right, and you guys will have to help me in terms of where that slide is located. So it's not there. Is this, no, that's just the perfusion versus diffusion limited gas exchange. I think this is when we're talking about ventilation. Might be close to here. Yes, right here. Okay. Can you guys see that? Okay.
Yes.
I'm gonna maximize my screen and minimize the view so I actually don't see you all. So if you do have a question, just unmute yourself and chime in. Okay, so I'm just gonna re-explain, and you might see my ceiling, but that's okay because I'm drawing on my computer here. What we're looking at here, and we've talked about this, we said that there are two things that cause an inward force on the lung, right? So the lung has an inward collapsing force, right? An inward collapsing force. Okay, so there's an inward collapsing force on the lung, and those inward collapsing forces are mainly due to two things, right? We said are due to two forces. So we've got one, it's going to be surface tension, right? S-U-R-F-A-C, surface tension. So surface tension causes the lung to recoil inward, right? Always, no matter what, surface tension is going to cause the lung to recoil inward. The second one is what? Bueller.
Elasticity.
Good, elasticity, very good. Elasticity, okay? So we've got, and I can't write today, sorry. Elasticity. So we've got elasticity. Those both are going to cause the lungs to recoil inward. So what do I mean by that? I mean that if I've got my lungs right here, right, and they are inflated, they don't necessarily want to be inflated, right? They want to be shriveled down to as small a size as possible, right? So they want to be like this, right? Because of surface tension and elasticity, those are causing the lungs to have an inward recoil. So if we're going to draw that, they're wanting to recoil inward. So these are arrows representing recoil due to elasticity and surface tension. So they're just wanting to always collapse, right? The reason why they don't collapse is because you've got the chest wall, right? You got the chest wall right here, and I'm drawing a big space in between the lungs and the chest wall. And in reality, that big space doesn't really exist. And we're going to just close it up there just for simplicity's sake. So you've got the chest wall, and then you have your diaphragm right here, okay? And it's a closed system. Now, at FRC, which is FRC, right? That's, what does FRC stand for?
Functional residual capacity.
Functional residual capacity, right? Capacity. And FRC is where the inward, if this is the lung, the inward recoil of the lung going this way is equal and opposite to the outward, whoops, big red one right there, we'll try blue, is equal and opposite to the outward recoil of the chest wall. So if this is the chest wall and the red is the lung, right? And picture it as a tug of war, right? And if you're pulling with 5 pounds of pressure this way, and the chest wall is moving with 5 pounds of pressure that way, there's a balancing point. Do you all see that? So there's a balancing point, and that balancing point is right there. Now, what if I increase the recoil of the lung? So no longer is it 5, but let's say 10. What'll happen, right? Well, then this purple, this line right here, which is the balancing point, which is FRC, it will move that way. So maybe the new balancing point is right here. Okay. And you say, well, why, what determines the new balancing point? Well, the new balancing point is basically where as you stretch the chest wall further away from its normal like level or normal stretch, if you will, or normal resting place, it's going to recoil outward with greater force, just like a rubber band, right? If I pull back on a rubber band an inch, it's going to recoil inward with, say, like 1 force. But if I pull it back to 2 inches, it's going to recoil inward with more force. So as you stretch this, as you move this, this chest wall moves further away from its native state, then that means it's going to recoil with greater recoil. And so no longer will that be 5, that will actually end up being 10, but your new balancing point will be right here. Does that make sense? Okay, so that's concept number 1, is that FRC is it stands for functional residual capacity, but in reality, it's where the inward recoil of the lung is balanced, equal and opposite of the outward recoil of the chest wall. Okay, that's at functional residual capacity. And we breathe from FRC, right? So we breathe from FRC. And so what's happening is, if we are, let me give them a black marker right here. There we go. So we've got FRC right here. And that's where the expanding force, another way to say it is the expanding force, is equal and opposite to the collapsing force. Okay. And so vital capacity, we know what vital capacity is, right? Vital capacity is the total amount of exchangeable air. What we're seeing here with this FRC point is that when we breathe, we're normally just kind of going like this. We're normally just breathing and, we're going increasing vital capacity by 500 increasing from FRC to about, or up 500 mils and then coming back down. And we're increasing and coming back down, right? When we inhale, we use muscles when we're breathing normally. And when we exhale, we relax those inspiratory muscles and we go back to FRC, because that's where the inward recoil of the lung is equal and opposite to the outward recoil of the chest wall. Now, as we inspire, if we increase our vital capacity, or I guess that's not a good way to say it. If we increase our inspiration so that we're getting more or utilizing more of our vital capacity, or if we just increase in our inspiration, what happens is that the chest wall right here, which is this first red dotted line right here, this chest wall, this one, right, at about 60% vital capacity, no longer does the chest wall stay on this expanding recoil or outward recoil force. It actually switches over to the collapsing force. Okay. We've exceeded where the native, like if you were to take a patient, right? Hopefully you never have to do this, but say you're doing, I don't know, you're doing an autopsy, right? And you cut through the sternum and rib cage, right? Or you basically collapse both lungs, it's, whatever else. And the chest is going to, basically undergo the respiratory system is going to undergo a pneumothorax, right? The lungs will recoil inward due to surface tension and elasticity, and the chest wall will go outward. Now, it doesn't just keep opening outward. The entire chest wall just won't like open up like in an Aliens movie, right? It'll recoil outward, but it'll recoil outward to its native conformation, right? Okay, that's at vital capacity. 60% is at its native conformation. So that when we get past that, when we inhale past 60% of our vital capacity, now the chest wall has an inward recoil as well. Okay. So like I said, when we get past this 60% vital capacity, the chest wall has an inward recoil and the lungs have a drastically, like a huge inward recoil, especially compared to FRC, because they're like a rubber band that's being stretched to the max. Does that make sense? And so this graph is going to be is useful for visualizing the chest wall recoil, looking at on the y-axis vital capacity, and also saying, okay, expanding force versus collapsing force. Okay. Now look at the lung right here. So this lung is, I'm going to draw it in green. The lung is this green line right here. Okay. Now the lung always has a collapsing force, right? It's always collapsing. It's always on the collapsing side because the lung is it never fully collapses. Does that make sense? Under normal circumstances, even when you do a maximal inhale to a maximal exhale, there will still be a collapsing force on the lung, right? So you do a maximal exhale and you try to get to like all, at the bottom, you try to get all of your vital capacity out. You do a maximal exhale. It's still going to be on this collapsing force side because the lung still has recoil even when you blow all the air possible out that you can. Okay, so the lung is always on the collapsing force side, but the chest wall is not. Now, under normal breathing conditions and at normal FRC right there, right, it does. It has a expanding force. But the reality is that when you get past your 60% right here, 60% vital capacity, then you are, and I'm drawing FRC right there. I should be drawing it like this, not there. You are, once you get past 60% vital capacity, then the chest wall has a collapsing force. Does that make sense?
Yes, that's very helpful. Thank you so much.
Gotcha. And so I was drawing the loop right here, the PV loop for tidal volume. It actually is not, it shouldn't be right there. It's actually more like somewhere over here, whatever percent vital capacity that we sit at with FRC. This is just showing you the balancing point right here. Okay. All right. Great. Hopefully that was helpful.
Dr. Brainard, quick follow-up.
Yeah.
What's the anatomical mechanism for the collapsing force of the chest wall?
So it has to do with muscles and ribs, right? It's just the fact, our ribs are curved, okay? And there is a springiness to ribs, right? They are bone, but there's cartilage in there that gives them flex. And so they are hooked onto the spine, right? To such a way via, cartilage and sinew, and also the manubrium and the sternum in such a way that it has a expanding force at FRC. Okay. So to answer your question succinctly again, once again, it has to do with the musculature and it has to do with the shape of the ribs. Okay. It's kind of like a bow, like, I don't know if you I don't know, seen Lord of the Rings. My kids are going through Lord of the Rings right now. And whenever, Legolas has got a bow, right? And so somewhere on that, right, you have to bend a bow to string it, right? So to put the string on it, you have to bend the wood. So the wood is going to be curved, right? It has that springiness on the wood, okay? Because you've basically locked the wood in that slightly bent state because the bowstring is kind of holding it in place, the tension of the bowstring. And it's similar, I mean, if you want to think of it that way, with the chest wall at FRC. There is a slight tension on it so that if some reason you were to give a pneumothorax and that bowstring were cut, right, it would spring open to some degree, which is why we see when individuals do have a pneumothorax, not always, but you may see that they have a, their chest may be puffed out a little bit on one side. Does that make sense, Justin? So musculature and bone structure.
Yeah, thank you.
Because even at rest, like skeletal muscle, like your biceps right here, skeletal muscle, that muscle still is under tension, right? It still is under tension. And it's the same thing with the intercostals, external and internal intercostals. There still is some tension there that even at rest, they're slightly lifting the rib cage a little bit. Okay, all right, great question. Hopefully that answered or clarified a little bit on that one. Any other, let's go with the next question. Anybody else have any other issues that they would like to go through? And I know some of you, and maybe some of you who are listening to this, have emailed me. I'm in the process of going through those emails. I'm going to try to get all caught up today and responding to those individually. I know some of you had some questions on the practice question, so I will respond to those after today's session. All right, what next?
So I have a question, maybe like 2 slides down from where we were just at. Forced expiratory flow volume loop.
Yeah. All right, so here we go. So you guys can see that. There we go. All right. So let's go over here.
Yeah, like
Right.
maybe, yeah, this one.
So what was your question?
So I guess I kind of get that like in normal you would have more lung volume expelled in the first second. But I guess I just don't get why, I don't know. Like I just kind of don't get like the restrictive versus obstructive,
Yeah,
why
yeah.
they're in those positions.
Okay,
if you know what
great.
I mean.
So a couple of things, and we'll review over the entire that entire area here. So remember that this graph is sequentially supposed to come after or be introduced, and it was, in slides after we talk about FEV1 and FEV2, or sorry, FEV1 and FVC. And the ratio in terms of emphysema versus pulmonary fibrosis, or kind of like these two opposing diseases, whether it's restrictive or obstructive. And then we have obviously our normal right here. So let's go over obstructive and restrictive real quick. And this is going to be real quick. So if you want me to elaborate, please let me know. What we have here is we've got the lungs. Okay. So I'm going to draw the lungs out right here. So these are normal lungs, we'll say, right? That's a horrible lung, sorry. We'll say these are normal lungs, okay? And I said for you all, to picture that the normal set of lungs has got 3 rubber bands, right? So we'll draw 3 rubber bands. Whoops, those are kind of bold. Let's go down to change right here. 3 rubber bands, 1, 2, and 3. We'll say those are 3 rubber bands around the normal lung. The rubber bands represent elasticity and surface tension, or the inward recoil of the chest wall, right? So this is a normal lung. If we take that same lung and so I'll draw the lung over here again, right? And we say that they have pulmonary fibrosis. We're going to say pulmonary fibrosis right here. When we said pulmonary fibrosis is if you take those 3 rubber bands and add 2 more. So we're going to draw the 3, 1, 2, 3. And now we're going to add 2 more rubber bands, because that's what pulmonary fibrosis is like. It's when you have increased recoil on the lungs. So now it's harder for the lungs to expand, or it's more difficult, or it takes more effort for someone with pulmonary fibrosis to inhale, right? It's actually easier for them to exhale because they got 5 rubber bands increasing the recoil. So they have 0 problem exhaling their breath, but they do have more of a problem inhaling. And so because they have more of a problem inhaling, remember that if we said this is FRC, if this is FRC, right? This line is FRC, and we have a collapsing, right? We'll say this is the lungs, right, wanting to collapse. And we have the chest wall, equal and opposite, wanting to expand, right? And we said that if they both have like 5, units pulling opposite, right? Whether it's pounds of pressure, millimeters of mercury, whatever else you need. There's 5 force going one way, 5 force going the other way, right? FRC is where they're balanced. But with pulmonary fibrosis, we've added more inward recoil. So instead of 5 now, it's got 10, right? And so if you've got the chest wall pulling outward with 5, and you've got the lungs pulling inward with 10, it's going to shift that FRC this way. Do you see that? It's going to shift the FRC this way. Now, as the FRC shifts more towards the lungs, do they increase in recoil, or do they decrease in recoil if we shift the FRC to a smaller degree? And that's for anybody. Answer it out loud, because I can't see you.
Did they increase in recoil?
Well, if you have a rubber band that's stretched, right, like this, and then you stretch it less, does that rubber band now have more recoil or less recoil?
Oh, less recoil.
Less recoil, exactly. So what happened with pulmonary fibrosis is because of the fibrosis on it, it inherently has more recoil on it. But as we move to a more like collapsed lung, native state of like a total collapsed lung, which is where a lung will go if you just let it go, it actually will have less recoil, right? So as we move this FRC to the, when I'm in my picture, it's to the left, this 10 is no longer 10. It maybe goes back down to, we'll say it goes to 7, right? So this is going to move over here, and the chest wall is the opposite. If the chest wall wants to be over here at this native line right there, and we are moving the FRC or basically causing the chest wall to move further away from its native conformation, then its outward recoil will increase or decrease. It's going to increase, okay? Because we're stretching we're moving FRC to a point that is further away from the native chest wall status, or you know, where it, if you will, wants to be. Okay, so the new FRC will move this way until a new balancing point is reached, and that new balancing point will be, and I'll just draw it in, we'll draw it in purple. Maybe that new balancing point will be right here in purple, right here. Okay, so now FRC, which was in the you know, at the level of the orange, is now at the level of the purple. Okay, where now you've got an outward of 7 and 7. It's the new balancing point. Okay, so that's pulmonary fibrosis. So with pulmonary fibrosis, what are we doing to the lungs? We are increasing recoil. Okay, what else are we doing? We are decreasing FRC. What else are we doing? We're decreasing residual, or yeah, we're decreasing residual volume as well with pulmonary fibrosis. And that's recoil, that's increasing lung recoil, to specify recoil. Okay, we're increasing lung recoil because where you had 3 rubber bands, now you have 5 rubber bands. Okay, does that make sense? Okay, all right, so hopefully it did. I'm assuming you said yes. So that's a normal lung. So let's look at the lung that has emphysema, right? Emphysema. So if a lung has emphysema, then it is going to be, right, we'll draw this. Instead of 3 rubber bands around it, it only has 1 rubber band, right? So we'll say it only has 1 rubber band. Okay, so the opposite happens in emphysema, which, you know, is that which happens in pulmonary fibrosis. There's less elasticity pulling the recoiling on the you know, or less elasticity of the lung in, you know, contributing to inward recoil. So therefore FRC will attain a new balancing point that is further away or at a larger lung volume than is normal. So, and here we go, we can actually say on this pulmonary fibrosis, we can decrease lung volume. Decrease lung volume. So emphysema is actually you're decreasing lung recoil. Okay, you are going to increase your FRC, or that point at which the outward recoil of the chest wall and the inward recoil of the lung are balanced. So you're going to have a greater FRC. You're going to have an increased residual volume, and you're going to have an increased overall lung volume because you have less recoil because you only have 1 rubber band. And you're shifting that FRC, right? Think of that FRC point as like tug of war, right? And when you exhale, passively exhale right before you inhale, I'll go to stop share. When you passively, right, you've got it going this way, the inward recoil of the lung, outward recoil of the chest wall, where they're balanced, that balancing point is FRC. Now, every time we breathe, even normally, we change FRC a little bit by contracting our diaphragm and external intercostals. We're changing that balancing point by you know, musculature, if you will. And so when we breathe in, we change our lung volume, and then because we're using our musculature to alter the size of the lung, which if you alter the size of the thoracic cavity, you increase the volume, that's going to decrease pressure, air is going to move in there. Okay, but we're using our muscles to do that. So let me ask you this: if I inhale like this with an open glottis and then hold it, is the outward recoil of my chest wall balanced by the inward recoil of my lungs? Yeah, because I'm using my muscles to hold it at that point. And then when I release those muscles of inspiration and exhale, then when no air is moving, we're back at a balancing point, except we're not contracting muscles at this time. Does that make sense? I think, Michelle, did you have a question? Or someone down at the bottom lit up. I didn't know if they had a question. Does that make sense, y'all?
Yeah, it makes more sense, I think, but
Let me explain the next graph. Was it you, Jenny, who asked about
yeah,
that?
it was
So
me.
let me go ahead and share. So now that we have that, let's go back to our graph. Okay. So because we said that with someone with a restrictive disease, and that's in purple, let me go right there. Restrictive is in purple. And so this restrictive right here, right? Their lung volume, because they have so much more recoil, their lung volume is going to be a lot smaller, meaning that they're going to, when they inhale, like when they start their inhale or their end their inhale, right? This is their maximum lung volume right here is about 3.2 or 3.3, whatever it is. And their maximal exhale is over here in terms of lung volume. Okay, so that's what this graph is showing you. It's just showing you lung volume versus expiratory flow rate. Okay, so the rate, or that's liters per second, or volume change, if you will. So that's someone with pulmonary fibrosis because they have so much restriction, right, on their lungs that it shifts them from the normal over their maximal normal is shifted from right around there to now it's right around here. Because what did we say individuals with a restrictive disorder have a problem with? What can't they do well? They can't what?
They can't inhale very well.
Yes, exactly. They can't inhale because they have more rubber bands, right? And so they were right here, right there, right? They could inhale all the way up to 5 liters. Look at that, all the way up to 5 liters right there. And because that's a normal, that's the peak of the normal when we're looking at the lung volume, for instance, at least on this graph, that's the peak right there. But someone with a restrictive disorder, because they have more rubber bands, it's way, 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 way harder to inhale. And so they can't actually inhale to as large a volume, and they can only inhale to now 3.2 or 3.3 liters because there's more restriction on their lungs. They can't inhale to as great a level. Okay. Now, the opposite happens with pulmonary fibrosis, right? Opposite happens with emphysema. With emphysema, they actually have decreased recoil. In people with emphysema or COPD, right, obstructive diseases, they have the opposite problem. They have a problem exhaling. They can't get enough lung volume out. And so they can only do a maximal exhale to about 3.3, or at least in this graph, 3.3 liters. Okay. Now, when they inhale, they can inhale from 3.3 all the way up to a maximum lung volume that's actually a little bit greater than a normal individual. Okay. And kind of the opposite, we said that pulmonary fibrosis patients, right, they have a problem inhaling, so they can't really inhale as much as a normal individual can, which is right over here. They have no problem exhaling. In fact, they can exhale all the way a little bit to a lower lung volume than a normal individual. Okay, so these are two diseases that kind of illustrate opposite ends of the spectrum. But if you look at total change in volume in terms of change, right, a normal individual has a greater volume change with a maximal inhale to a maximal exhale than someone with pulmonary fibrosis or someone with emphysema. Okay, do you see that? And then over here on the y-axis, we're just looking at speed or flow rate. So in terms of flow rate, maximal flow rate that can be accomplished, emphasmatics have the worst of these 3 different types of diseases in terms of, or 2 different types of diseases compared to normal, right? Because emphasmatics have a problem exhaling, so they can't generate enough force to exhale a large amount of their lung volume. And then you've got pulmonary fibrotic patients right here, they would be able to generate if they could inhale as much as a normal individual, they would actually be able to generate a higher expiratory rate than a normal individual. But because their lung volume is restricted to only that level right there, they don't have enough volume, or they can't get enough volume in their lungs to generate a high enough flow rate to overcome a normal individual. And a normal individual has not only the highest change in lung volume, which you see down here, but they also have the highest peak flow rate. And that's what this graph is representing. And why does that matter? Because you're going to have patients who smoke, you're going to have patients who vape, you're going to have patients who come in to your clinic and are messed up, right? And you know, vaping, like that's like a new thing in the last couple of years where students are coming in, not students, but patients are coming in and they're 17, 18, 19, 20. They've only been vaping for a year or two, but because a lot of these vape cartridges had not only, what did they have? They had like vitamin E and different oils and all this other stuff, which is not meant to be inhaled. It coated the lungs and it actually is destroying the lungs. And so they're coming in with restrictive and or obstructive looking lungs as though they've been smoking for 40 years. And the reality is they've destroyed their lungs in a very short amount of time. Anyway. Okay, did that help for your question?
Yeah, it helped a lot. Thank you so much.
Great. Okay, great. Okay. Okay. All right. Next question.
I've got a quick question.
Yeah.
Maybe it's not quick. I'm not really sure. I'm confused on just the general. You may have already talked about this. I just joined a few minutes ago, so I'm sorry if so. I'm confused on like the general charts for just normal breathing. There was it was right before we talked about lung volumes and capacities in the PowerPoint.
Let me share. All right.
Just like the difference between like a full, you'd mentioned like talking about what happens at a full inspiration, what happens at the end of a passive expiration, and like what's specifically occurring with like intrapulmonary pressure and all of that.
Up, is it up or down where I'm at now?
It's higher than that. It's like pretty early on.
All right, tell me when to stop.
Okay.
Wait, is this the one you're talking about?
Yeah, go down. You're lagging just a little bit on my screen. A little bit more down.
A little bit more down past the cat. Okay. This one?
It was the one, I think you mentioned it as like being an extra like graph picture. You're like, oh, this is just something that, hang on, let me tell you the slide number real fast.
Yeah, for sure.
Okay, it's down from, it's like 3 down from that one.
This one?
Okay, 3 down from there. Sorry. It's that one right there. Yeah, that one.
Okay, so this slide is just looking at what's happening during a normal breath as you move from FRC, away from FRC due to muscular contraction, and then you move back to a normal, a normal FRC volume where with muscles relaxed and open glottis, you have no air movement. So let's talk through that. So it basically, this slide is the same thing as this slide. It's just showing you it in sequential order, whereas this one is just looking at the graph, right? So if we're looking at this slide right here, we've got, and this is, let me go to draw. Here we go, draw. We've got this little thing right here that represents the lung. Okay, that's an alveolus, right? And then you've got your chest wall, which is right here, right, like this. This is representing the chest wall right there. Okay, this space in between so if this is the alveolus right here, right there, that's the alveolus. This part right here, that's the intrapleural space, or the space in between the visceral pleura, which is on the lung, and the parietal pleura, which is lining the chest wall. Okay. And so we're just looking at, over the course of a single breath, how those different volumes, I guess not volumes, but how those different pressures are changing. So if we've got this, let's start at the end of expiration. Okay, so we're going to start right here. So you just passively exhale. That's expiration right there, right? So we're going to passively exhale. Now where atmospheric pressure right here, right, and alveolar pressure are balanced, right? They're equal. So there's no net air movement there because it's the end of expiration. And we said at the end of expiration, right before a normal physiological inspiration, that's FRC. So we've got FRC right there. And the inward recoil of the lung is balanced by the outward recoil of the chest wall. In normal FRC, we have a negative intrapleural pressure. Do you all see that? It's a negative intrapleural pressure. And we know that because of the outward recoil of the chest, of the lung, inward recoil of the chest wall. That's going to create a negative pressure. I thought those opposing forces. Okay. So this is showing you that we've got a negative intrapleural pressure of -5 right there. Okay. And this right here is representative of the transmural pressure, which is intrapleural minus alveolar, right? Or sorry, alveolar minus intrapleural. And that's going to be a +5 because it's equal and opposite, right? Okay. Are you still on the same page with me with the transmural / transpulmonary pressure?
Yes, sir.
Okay, great. Because I'll explain that too, but I mean I explained it, but I'll draw it out. So transpulmonary or transmural pressure is, remember, it's the alveolar minus the intrapleural. So now when we start to inspire or breathe in, what have we done? We've contracted the diaphragm and we've contracted the external intercostals. Okay, and that's going to cause a volume change in the thorax. That volume change in the thorax causes a pressure decrease in the lungs, and that's what we see here. The lungs move from a 0 up there. Now it's moving to a -1 compared to atmospheric, right? When we inspire. All right. So we've created negative pressure in the lung itself. That's good. That's going to cause a pressure gradient. And so air will move from the atmosphere into the lung because it's moving down a pressure gradient. Okay. So we're expanding the lungs. We're filling the lungs. Now, when we inspire, what's happening is our intrapleural pressure is becoming more negative. Okay. Why is it becoming more negative? Because we're stretching the lungs. And so just like a rubber band, the more you stretch that rubber band, the more that rubber band wants to recoil. And if you let go, it will recoil with greater force. So the same thing's happening when we are inspiring, where we're pulling or expanding the lung, and just like a rubber band being stretched, it's going to have more recoil, inward recoil. And that is going to cause a more negative, or going from a -5 to a -6.5 intrapleural pressure when you are inspiring. Okay, does that make sense? So at this point, at mid-inspiration, if we measure these different pressures, right, air is still moving in because we've got a -1 right there in the alveoli because we've expanded the chest wall. If intrapleural pressure is going from a -5 up here to now it's a -6.5. Okay, and then what is transmural or transpulmonary pressure? Well, it's alveolar pressure minus an intrapleural pressure. So if you go -1 minus a -6.5, you add a positive, that's going to equal +5.5 for the transmural or transpulmonary pressure, which is what we see right there. Does it make sense?
Yeah.
Okay, great. So now we're going to continue to inspire. That was just mid-inspiration. So we're going to continue to inspire and we're going to finish our inspiration. So what do we mean by that? We mean by this. At that point right there, I breathed in, air moved, but then with an open glottis, air stopped. Why did air stop? Because it equalized between atmospheric and lungs pressure, that is. So when air is moving, there is a pressure difference. When air stops moving, there is no more pressure difference. But when we inspire, we are at a higher lung volume or a larger lung volume than we were when we first began to inspire. So, and that's what C is showing you. C is showing you at the end of inspiration. And inspiration. Okay. So at the end of inspiration, the lung is stretched to its maximum, or at least it's not its maximum, but in this diagram, to the maximum that it's going to be in this diagram. And it's stretched more. So intrapleural pressure is going to be at its most negative compared to atmospheric pressure, right? And that's a -8. Now we said at the end of inspiration, no more air is moving. And that makes sense because if we've got a negative, or if we've got a 0 atmosphere and a 0 lung or alveolar pressure, then there's not going to be any air movement. But the lungs are still at a greater volume because we just inspired. And so if we've got a -8 intrapleural pressure, then that means our transpulmonary pressure, transmural pressure, that is the expanding pressure of the lungs, is going to be at a +8. Okay, that's at the end of inspiration. Then we relax the muscles of inspiration and we start to expire. And basically the entire process that we just went through is gone through in the opposite direction. The lung has been stretched out. And so now we are going to allow the lung to recoil, right? Recoil inward. And that's going to mean that there's going to be a positive pulmonary pressure, right? So that if we've got positive pressure inside the lungs, or if it's a higher pressure than atmospheric pressure, then air will move out down the pressure gradient. Okay. And at this specific time point, we've got a +1 for the alveolar pressure and a -6.5 for the intrapleural pressure. And that is going to, if you do +1 minus a -6.5, and that means it's going to be 7.5 transpulmonary pressure right there, because that's what transpulmonary pressure is. It's alveolar minus intrapleural pressure. And then we're going to continue to expire until we go back to FRC, where the outward recoil of the chest wall is balanced by outward recoil of the chest wall is balanced by the inward recoil of the lungs. And we're back to square 0 or square 1. Okay. Dadgummit, it keeps booting me. I think this is a OneNote issue. It only does it when I'm recording. So bear with me here as we go back. Okay. So on the left-hand side of that slide, right here, it's just showing you what's going on with the volume of a breath during inspiration. The volume is starting at A, and then it's increasing. And then at the end of inspiration, you have the highest lung volume, right? And then it's going to, when you expire, it goes back down to FRC, okay? That's the volume. Intrapleural pressure, this is saying that as we inspire, intrapleural pressure is at its most negative at the end of inspiration, okay? And then with this one, alveolar pressure, in order to get air to move into the lungs, we have to decrease, and in this scenario is -1 right there, our alveolar pressure compared to atmospheric pressure. And then we've got atmospheric pressure over here, or alveolar pressure increasing to a +1 right there, so that we can blow air out during expiration. All right, did that help at all? Does that make sense?
That was super helpful. Thank you. Appreciate it.
Great. All right, next question.
Sorry, just going back to the slide you just left. In terms of terminologies, mid-inspiration and end of inspiration, are they the same term?
No, great question, because I might ask that on an exam or something. I might say during mid-inspiration, do you have a volume change? Is volume changing during mid-inspiration?
Yes.
Yes. Yeah. Volume is changing, right? Air is moving into the lungs. Let me ask you this. In mid-inspiration, is the alveolar pressure, is it still lower than atmospheric pressure?
Yes.
Yes, it is still lower than atmospheric pressure. towards the end of inspiration, is alveolar pressure increasing or decreasing or staying the same? I'll say that again, towards the end of inspiration, not at the end of inspiration, but as we move from mid-inspiration to the end of inspiration, is alveolar pressure increasing or decreasing?
Increasing?
Yes, that's key right there. Do you see that? Do you see that? So during mid-inspiration, that's when we have our most, I guess you could say, negative alveolar pressure. But once that point is reached, then you actually see alveolar pressure increasing back to baseline, and then it'll transition and continue to increase as we move into expiration. And then you could do the same thing with from mid-expiration to end of expiration. Is alveolar pressure increasing or decreasing? And the answer is that alveolar pressure is decreasing as you move from mid-expiration to end expiration. Alveolar pressure is decreasing because it's re-equalizing as you're moving that air in, right? That air now is that, or that pressure gradient is diminishing and going towards zero because you're moving air in and it's equalizing the pressure. Does that make sense?
Yes, thank you.
Yeah, that's a really good question. That's one of those little caveats or kind of details that you don't really think about all that much, but it's a really important question, and it may show up on the exam.
Can I ask a quick follow-up question to that?
Yes, go ahead.
How would this change for when we do like a max inhale, like a, like a forced inhale or a forced exhale, when we start getting those positive intrapleural pressures and stuff?
Well, you don't ever get positive intrapleural pressures with a maximal inhale, or even the only time you're going to get a positive interpleural pressure, and remember, it's not just a positive interpleural pressure, it's a positive intrapleural pressure compared to atmospheric pressure. Okay. Does that make sense? So if you do a forced expiration, like you're blowing into a balloon and it's a really tough one, it's not then you can get a positive intrapleural pressure compared to atmospheric pressure, but you can never, ever, ever, ever get a interpleural pressure that is greater or more positive than the alveolar pressure. You never can do that, no matter what you do, unless you get stabbed because you're walking down that alleyway your mama told you not to walk down and you get a pneumothorax. Okay. Anytime intrapleural pressure is that it equals alveolar pressure, you will get a pneumothorax. Okay. Does that make sense? So make sure that you understand the difference between the two. Okay. One of them is saying you can get a positive intrapleural pressure when you do a forced expiration. But what are we saying positive in relation to what? In relation to atmospheric pressure. Okay. You can never get a positive interpleural pressure in relation to alveolar pressure under normal circumstances, because if you do, you're going to get a pneumothorax. Does that make sense?
Yeah. Okay. Thank you.
Okay. Now that's like normal physiological breathing. That's just normal. That's normal physiology, right? You have a normal person and you tell them to blow into a balloon. That's normal physiology. Remember, some of those rules change when we do ventilation. I don't think I have any questions. Actually, let me just look quick. I don't have any questions right now that on my questions of the exam that deal with what I went over with Dr. How do you pronounce it? Hassana. Anybody know? I don't. Dr. H. We call her Dr. H. That the thing that we went over with you all with her those ventilator, right? Remember those ventilators and PEEP and PIP and stuff like that. I don't have any questions on that on my portion of the exam. Okay, so my portion just like pretty much focuses on the physiology, and I talk about. I have questions about. I have volume questions where you have to calculate the different types of volumes I give you 3 volumes, you give me the 4th. I have questions that look at and ask you to calculate partial pressures of oxygen or CO2 or some gas, which I'll give you all the information you need to, either in the atmosphere, the partial pressure of the gas in the atmosphere, the partial pressure of the gas in the trachea, or the partial pressure of the gas in the alveoli. Does that make sense? So I have those type of questions on here. I have questions on different types of things that will affect, blood oxygenation, blood CO2. And we talked about certain things that would affect that. We talked about you have a patient come in who has a blocked left main bronchus. How will that affect? And I'm not reading off here. I'm just out of my mind. You have a patient who comes in with who's choking and has a left main bronchus block. What would that, or which of the following does this mostly look like, or does it mostly relate to, or which of the following would you suspect of this patient? And the reality is, when you block the right main bronchus, you are effectively creating what? You are having perfusion, but not ventilation. And when you have perfusion, but not ventilation, what are you creating?
Is it a right to left shunt?
Exactly. You're creating, you're basically creating a VQ mismatch in that portion that's being perfused, but not ventilated. And blood is coming into that lung, that portion of the lung, deoxygenated blood. Guess what's leaving? Deoxygenated blood. So it's mimicking or increasing a right to left shunt. And a right to left shunt does what to your AA gradient? Increases your AA gradient, right? Your AA gradient, big A to little a. Big A is alveolar gas, and little a is your arterial blood gas, okay? And so you're increasing that because what's happening is when we look at our AA gradient, we're looking at the ventilated portion, right? And the alveoli collectively and all, like if you were to put it all in the alveoli, compared to the systemic circulation. So a right to left shunt will increase your AA gradient. Okay.
Dr. Brainard, I threw a question in the chat.
Oh, sure.
Has to do with the different types of pneumothoraxes, whatever the plural is, that is, just rationalizing like the pressure differentials between the pleural
Sure.
cavity and the atmosphere,
Yeah.
especially for a closed pneumothorax. I'm having a hard time.
Let me share my screen. And remember that okay, I'm just going to tell you right now, I don't think I have a question on the differences between the pneumothoraces on the exam, okay? But I put that in there, and remember, I put the caveat, I was like, I might be stepping on Patho's toes a little bit, or might be, encroaching on their subject matter a little bit. But I did want to bring it in there because I thought it illustrated really well what's happening in terms of that. So let me go ahead and share my screen, and then we'll go to that slide. So I think it was, is it down? I think it's down here. Sorry about the lag. I know there's some.
I think it's 3 prior to this.
Oh, prior. Okay, so up.
I think other way.
There we go. Yeah, I think my screen is delayed by like 5 seconds. I think the audio comes through, but I think the screen is delayed. Okay, so this one, looking at the different pneumothoraces, what's happening here is that you've got a closed pneumothorax, meaning that the chest wall has not been punctured, right? The chest wall right here has not been punctured. So no spork for you, right? No spork in the chest wall, okay? So, but what's happening is you have a pneumothorax. So what did we say has to happen if you got a pneumothorax? What had to have happened? What equaled what?
Atmospheric equal to intrapleural.
Yes. Yeah, well, yes. Yeah. Atmospheric and intrapleural equaled, right? And so what's happening is with this type of pneumothorax, I'm going to zoom in and hopefully it doesn't like throw me back a couple of slides. What's happening here is you've got a tear or a rip in the visceral pleura of the lungs somewhere. and you've got equalization between alveolar and intrapleural. And alveolar and intrapleural are never supposed to equal, right? And yeah, oh, that's right. It was alveolar. I think I said, you said atmospheric, and I agreed. It's actually not atmospheric. It's alveolar and intrapleural, right? So what's happening with a closed is when you try to breathe in, air is coming in like it normally would, right? It's going and filling in this lung. It's coming in here, but then it's going straight into the intrapleural cavity. And remember, negative pressure sucks. And so the negative pressure in the intrapleural cavity is the only thing that's keeping the lung open, right? So if you allow air to get in to this intrapleural cavity, then it's going to equal atmospheric / alveolar, and then it's going to cause the lung is no longer held or stretched open, right? It's going to collapse inward. Where are you going to see these types of injuries as a physician? Car crashes. Car crashes, when you have that certain change in inertia, right? And you've just got that blunt force, just impact or quick change in inertia. Remember, these lungs are very delicate tissues and they're hanging, right? So if you move back and forth really fast, too quick, like you could potentially rip that tissue. So you're going to see this right here, maybe a rip in the tissue where you've got a car, someone in a car crash comes in with a pneumothorax. Now, obviously check for an open pneumothorax, because maybe a piece of shard, a glass shard, broke through their thoracic, thoracic wall, and air is getting in that way. Maybe air, they've got something that went not only through their thoracic wall, but it actually went through their lungs. So maybe they have an open and a closed, or they have a punctured visceral and parietal pleura. So maybe it's both, right? You think, oh, I'm going to plug this. I'm going to plug the closed and then pump, get an air valve in here, right there. We'll call that an air valve, so that every time air, comes in, maybe you intubate them and open up their lungs forcibly, but their lungs aren't opening up. You're like, why aren't their lungs opening up? Well, it's because you still have a hole maybe right there in the lungs, in that example that I was giving. Okay. Another example of this is maybe like football players or people who are tall and they suddenly, they fall and they have like that sudden boom, just that really big like change, or that really big inertial change in their body that could cause a rip in the visceral pleura. Okay. And so that's a closed pneumothorax, is where pleural cavity pressure is less than atmospheric pressure. Does it make sense? Basically,
I'm still struggling with like the closed pneumothorax. Like if pleural cavity pressure, if like pleural cavity pressure is less than atmospheric, that kind of implies, but it's still pushing the lungs in, then it kind of implies that the pleural cavity pressure is like greater than the alveolar.
Yes, because a closed pneumothorax is what can be termed, and remember, this is more bordering on the patho than the actual physio. And I'm not actually testing you on this slide right here, right? A lot of times as the lung collapses, when you have, say, let's look at this right lung or left lung right here. So this is a healthy lung right here. Okay. If you were to have like a hole for some reason, blunt force trauma in the visceral pleura, the lung and air is getting into the intrapleural cavity, the lung will start to recoil inward, right? It'll start to collapse. But as it collapses, it seals that hole. Does that make sense?
Yeah, I think so.
So it can like self-seal that hole. So it can be like partially collapsed, but still have negative or slightly negative, not as much as it needs to be for a normal functioning lung, but it can still have like a negative intrapleural pressure in there. So it's just saying that when we're looking at pneumothoraces, that a closed pneumothorax, the pleural cavity pressure is still less than atmospheric pressure, okay, in that instance. But with like an open, because air literally is moving from the atmosphere into the pleural cavity, it's going to be equal to it. And then with a tension pneumothorax, what's happening is that this open pneumothorax is allowing air to get in here, and it's closing, like it could be like a sucking wound. And every time they inspire, air's moving in here, but then and the expire, it's closing, so air cannot get out. So if air tries to get out, it can't, right? Because it's like a closing one, it can't get out. And therefore, as the chest wall collapses, it increases the pressure in here. And that's putting tension and pushing on all the organs, including the blood vessels. And so that's where the pleural cavity pressure is actually greater than the atmospheric pressure. All of these are examples of pneumothoraces. So will all of these have intrapleural pressure that is closer to atmospheric pressure? Yes, 100%, than a normal lung, okay? Because a normal lung intrapleural pressure is supposed to be negative, on average, -4 or 5 millimeters of mercury. Okay, this one in the closed pneumothorax, maybe it's only -1, but it's still slightly negative compared to atmospheric and or alveolar. Does that make sense? Did that help kind of?
Yeah, it did. Thank you.
Okay, great. Okay, cool. All right. What else, y'all? Woo, it's warm in this room. I built this room and I forgot to put a vent in. Okay, what's up?
I have a question about alveolar ventilation.
Sure.
So one of the equations we have is alveolar ventilation equals tidal volume minus dead space times respiratory rate.
Okay, alveolar ventilation equals, what'd you say? So that's VA, so V dot A equals, say that again, it's what?
Tidal volume
Okay.
minus dead space
Yep.
times respiratory rate. And my question is that anatomic dead space or physiologic dead space?
All right, great. So let's go up. So I think that's looking at actual just all dead space. Usually when we're doing this, let's go back up here. Let me see where I've got this in my notes. I think that was at the beginning portion. Let me see, lung mechanics. I think it's a little bit before lung mechanics. Actually, no, it's after.
Yeah.
You know what slide I talked about that? Alveolar. Let me pull it up.
Oh,
You're fine. I'm pulling it up right now. Do alveolar dead space, or sorry, alveolar ventilation. Control F. Okay, so that's going to be slide 68. So that is going to be right around here. Keep going. Keep going. Where are we? Okay, here we go. I think we're talking about ventilation here. Okay, great. Okay, so with this one, let's see, respiratory volume, exchange of air between the lungs, ventilation, minute ventilation. So we get over there. Let me get that one. All right, respiratory rate. Here we go, alveolar ventilation. There we go. That's right. So this one, normally, unless you are told like, alveolar dead space is, is increased or whatever, really you assume that it's anatomical dead space, unless they have like, something where you've got ventilation, but no contribution to gas exchange. Does that make sense? Because that's what dead space is you've got ventilation, but no perfusion. So you assume right here that this is just referring to the 150, 150 mils of dead space, or I think there was a quick and dirty way to remember it is like 1 mil of dead space for every pound of body weight. Obviously, that only works to a certain degree, right? That doesn't mean a 600-pound person has a 600 mil dead space. That there is a limit to that quick and easy one. But your question is what equation do we use? Is that what you're asking?
No, so actually my question was really the difference between like when we would just assume that it's 150 and when we would use the body weight times.
Oh, okay, gotcha. So it really is dependent upon what, at least for my questions, if I ask you and I say, assume dead space is, assume normal dead space, right? Default right there is 150. Okay, so that's what you would do. And let me just double check. I don't think I have any control F. Oh man, let me see right here. Let me just do this. I don't think I can search in Excel. Control F. Oh, okay. Let me just go through here. Yeah, I don't think that I have any. I'll double check on them. If I give you the weight of the individual and I don't say like assume normal dead space, say I put them at like 182 or something like that, 182 pounds, then you can use that 182 for the dead space. I don't think I have any like that. But I want to make this. I don't think I have that. If I say assume normal dead space, then it's going to be 150. Okay.
Okay, thank you.
Cool. All right. Back. What's up? Any other questions? Any other areas that you want me to review?
Yes, I have two questions. One is about that Kaplan question that was in the PowerPoint about like why that person has the greater alveolar ventilation.
Yeah. Let me go ahead and share my screen. Share. Share. Okay. I think it was. Question right here. Yeah, right here. No, that's not it. It's this one right here. Right?
Yes, the one like person A versus person B. Could we just talk through that again?
Yeah, so with the with that individual, whoops, over here, with that individual who has this, what you need to remember is that when we look at alveolar ventilation, what's the equation for alveolar ventilation? Anybody?
Isn't the tidal volume minus dead space times the respiration rate?
Yeah. And so if we have person A and person B have like the same dead space, right? So it's tidal volume times the respiration rate, right? Which is what we're doing right here. We're multiplying 600 times 10, that's 6,000. 300 times 20, that's 6,000, right? So their total ventilation, right? That's total ventilation is the same, right? But over here, if we look at tidal volume, right, and we say both of them have a normal dead space, right, so then we would actually take their tidal volume minus 150, right, and so 600 minus 150 is 450, right, so 450 times their respiratory rate. So 450 actual, that's the actual amount that's getting into their gas exchange regions, right? Times their respiratory rate. So times 10, 4,500 for total ventilation. Does that make sense? For sure, or not for total, but for alveolar ventilation right there. And then you've got 300 minus 150. That's only 150. And 150 times 20 is 3,000. Does that make sense? So if you look at the amount of air that someone is getting to their alveoli, what's happening is that they might have the same total ventilation, but when you calculate dead space in here and you look at their tidal volumes, if their tidal volume is only 300 mils, dead space is effectively half of that. Okay, because their dead space is the same as anybody else. But if their tidal volume is 600 mils, even though they have half the respiratory rate, they still have greater alveolar ventilation. Does that make sense? And that's why it says in rapid, shallow breathing, total ventilation may be above normal or normal, but alveolar ventilation may be below normal. So it's more, and all that to say is, if you have a patient come in and you're just like, okay, what is total ventilation of your patient? and say 6,000 mils per minute is normal, and they're getting 6,000 mil per minute, you think, okay, well, then the ventilation is fine. That doesn't mean that their body is getting enough gas for it. They could be hypoxic there because they're not breathing enough, because don't just look at total ventilation, right? You have to look at tidal volume and you have to look at respiratory rate. And that is going to, that will give you a better estimate of looking at their, okay, how much gas are they actually getting to the gas exchange zones? Did that make sense? Did that help?
Yes, that makes way more sense. Thank you.
And yeah, so in this example, we're incorporating dead space, and the larger tidal volume of person A minus normal dead space allows them to, even though their rate of respiration is lower, is half, they still have 4,500 mils getting to respiratory zone. Whereas this person B individual, their tidal volume is shallower, right? It's at 300. Well, dead space is still the same, right? 150. So you subtract dead space, and even though it's double the amount of breaths, they still are under ventilated, basically, of their alveoli. So they're probably going to be hypoxic. Okay, great question.
Thank you. And then my second question was, can you just define hysteresis again?
Yeah, so hysteresis is a delay. It's basically when it's a delayed result of a driving force. So if you've got a driving force, and the best way to do it is like pressure, right? Pressure with a balloon. So an example of hysteresis is when I blow, or when I change pressure. If I'm blowing in a balloon and I change pressure from 5 millimeters of mercury up to 10 millimeters of mercury, right? I'm increasing the pressure. You would expect that volume would increase concomitantly and accordingly, right? But it doesn't, because I blow and I increase from 5 mils up to 10 mils of pressure. The volume doesn't change really. I go from 10 to 15, volume may increase by like 1 or 2%, but it's not increased enough. It's not increased like proportionally. And then I go from 15 millimeters of mercury pressure up to 16. And then all of a sudden that balloon, the force, the pressure you're pushing now has overcome, right? The recoil on that balloon. And all of a sudden that balloon now goes, just by 2 or 3 millimeters of mercury pressure change or increase in your mouth, it increases now in size of in volume. Okay. So why do I say that? Well, because the lungs, let me go to share my screen. The lungs are a similar thing. When we have, and I'll go to the hysteresis curve. I think it was, surely that one is up front. Let me see where this one is. Control F, hysteresis. Can't even spell the darn thing. Okay, so that is going to be slide 48. So that's a picture of, okay, I think, yeah, right here, hysteresis. So it's when the physical property lags behind the changes that are causing it, right? So we normally in this curve are moving or breathing at FRC. So we're breathing right here, right? We're staying within that small, excuse me, that small area. So we're breathing in, transpulmonary pressure is increasing, and then we're exhaling because we're only moving 500 mils. Does that make sense? For a tidal volume is only 500 mils. And remember, total lung capacity, right, is around 6,000 mils. And your vital capacity is only a little bit lower than that, right? The only thing you can't move is your residual volume. So your vital capacity is like, we're talking liters, right? 4 to 5 liters is your total amount that you can change your lung volume. But the 90% of the time that we're breathing, we're not breathing in maximal inhale, maximal exhale, right? We're not doing that. We're just breathing tidal volume, 500 mils. So when we're moving just that small 500 mils, hysteresis really doesn't play a big role in breathing, in normal breathing. Where it will play a role is when you have a patient come in with a pneumothorax. When a patient comes in with a pneumothorax, they have a, look at this, their total lung volume right there. Their total lung volume is super low. It's collapsed, right? So their lung volume is super low. Okay. Transpulmonary pressure is 0. Remember, transpulmonary pressure is distending pressure on the lungs, or it's alveolar pressure minus, that's P alveolar minus P intrapleural. Intrapleural, right? So it's alveolar minus intrapleural. If that equals 0, that person has a pneumothorax, right? And so if your transpulmonary pressure is 0, you think, oh, okay, well, let's increase our transpulmonary pressure and let's increase it from 0 to 5. Let's increase it from 0 to 5 by changing the intrapleural pressure or, using positive pressure. Let's change it. But look at lung volume. This curve right here, what happens to actual lung volume when you move from 0 to 5 pressure? You've increased pressure from 0 to 5. Lung volume does not change. You see that? Lung volume really did not change at all. Let's go from 5 to 7. Lung volume still does not change, right? So we've increased the pressure, but volume is not changing. That is hysteresis. It's when you have a delay in the onset of a change due to some force, right? So, but now if you increase the pressure from 7 millimeters of mercury transpulmonary pressure to now up to 10, look at that. Now we're starting to see an increase in the volume. And then when you go from 10 to 15, or actually let's say just 10 to 12, you see a huge jump in the volume, right? Total volume. You almost went from like 30% all the way up to 50% with just a 2 millimeter of mercury change in transpulmonary pressure. But when you did that over here, you had no volume change. In fact, you did it 2 right here, 2 right here, 2 right here, 2 right here. Like you did it multiple times and there was still no volume change, right? And that's because when you try to inflate a deflated lung, it's way harder and it takes a lot more pressure change to have to have a change in volume initially until you overcome the recoil on the lung. So let me ask you this. Good test question. If you've got a lung right here, is this lung at that point, is it high compliance or low compliance? And remember, compliance equals a change in volume for any given change in pressure. So are you changing the pressure here at this level? Are you changing the pressure?
Yes.
Yeah,
Yeah.
you're increasing the pressure change, right? You're increasing the pressure. So this number, the denominator is getting bigger. Is there a concomitant volume change at this point? No. So when you've got a low number up here and you've got a really high number right here, compliance is going to mean that it's low compliance. Does that make sense?
Yes, this makes way more sense.
Okay. And so when you've got that at collapsed lung, it has way less compliance because the concept or the I don't even want to call it a concept, but hysteresis plays a larger role when you have low compliance or low volume lung because it's collapsed. Okay. And so hysteresis is just a term that we use to describe when the physical property lags behind the changes that are causing it. And so hysteresis plays a much bigger role at lower lung volumes and even more a huge role at when lung volumes are so low that they've undergone a pneumothorax or they've had total lung collapse. This is why we talked about in our ventilators positive and expiratory pressure, right? You need PEEP to be something. It has to be above 0 because that's going to keep those alveoli open and recruited. And when they're open and recruited, they're not collapsed and they're not increasing and or contributing more so to the inward recoil of the lung. Because as the lung, remember, we said this, if you've got a lung that's normal size, right? And then you've got a lung, we'll go this way. You've got a lung that is a lot larger right here, right? So we'll go that way. We'll go from that lung to this lung, and then we'll go to a lot smaller lung up here. A smaller lung, maybe some that are collapsed, right? Right? The water molecules in the lungs don't really change, right? So in terms of the number of them. So the water molecules, we're going to do like that, right? In this lung, they're about this close together. And the bigger lung, if you've got 5 right here, 1, 2, 3, 4, 5, you're going to have 5 right here. The water molecules are further apart in the large lung. 1, 2, 3, 4, 5, 6, I think on that one, but they're way closer together. 1, 2, 3, 4, 5 in the collapsed lung. So therefore, remember, water molecules want to stick together, and so those collapsing forces are going to be greater, which is why it takes more pressure to inflate a deflated lung. It's because the surface forces are greater in that deflated lung, with or without surfactant. We're looking at size right now, simply because the water molecules are closer together, and therefore they are holding more strongly to one another. Does that make sense? Did that help?
Yes, thank you so much.
Cool, awesome, great. Okay, cool. All right. Next question. Anybody have any other questions? I know we're getting to the end of the
Yeah.
time here, but anybody have any other questions? Somebody chimed in there.
Can
Yeah,
you
so,
quickly
no,
Okay,
go ahead, Mochi.
Moji and then Lindsay. Moji first and then Lindsay, and then I'll answer both of those. Go ahead.
Okay, can you quickly talk about the resistance as you go from trachea to the alveoli, please?
Can I talk about the residual?
Like resistance, does it increase? There was a question and I kind of missed that.
Yeah, so you're referring to the question that you missed. I think I know exactly what question you're talking about. Okay, so the question was something along the lines of when we increase, so the resistance, if you've got your graph right here and you've got resistance here, and then you've got your trachea right here, and then we'll say all the way to your alveoli, right? So how does resistance change? Well, resistance is going to increase a little bit initially, and then it's going to precipitously drop down, something like this, right? That's kind of the curve right there. So the question was, if you increase velocity, what will that do to resistance as you move down the respiratory tree, right? So we said that velocity contributes to resistance. If you increase velocity, you're going to increase resistance. Because what is resistance to? It's resistance to flow, right? So if you increase velocity, you are inherently going to increase resistance to that velocity. The opposite is true. If you've got a tube and the velocity of blood through that tube is, if the velocity is 0, that is, the blood is not moving, are you going to have resistance to flow to that blood moving if you have 0 movement? No, it'll play a minimal or no role at all. So you have to know this relationship, right? If you increase velocity, inherently you're going to increase resistance to that velocity. So in that question, what I was asking, if this is resistance up here, I'm saying that you increase velocity throughout the entire lung system. So that means that now you're just basically going to move this curve up. So in relation to a normal individual, they will have the same, a very similar looking curve. It's just going to be moved up.
So if the question includes velocity, we should always go in the direction of the velocity, right? It doesn't matter if the resistance is decreasing as you go down the alveoli.
Well, total resistance is still decreasing as you go from trachea to alveoli in both of these curves. But what's happening here is you've just increased the velocity, and so therefore the resistance is going to, on the same level, concomitantly move or increase, but it's going to follow the same curve as you go down from the trachea to the alveoli. Does that make sense? And I mean,
So like
eventually it'll probably tailor off, because remember, you have movement of gas at the very alveoli is due to diffusion.
So like in a question, if you ask, so this question was asking how would it affect total resistance of to airflow from the trachea to the 4th division, and
Okay.
how would it affect when it goes from the 5th division to the terminal
So
bronchial?
how does increased velocity affect resistance here? Do you see it increase it? So it increases it right there. That's the
Yes.
trachea to the 4th.
Mhm.
And you've got from your, let's do from the 4th all the way down to the end. Do we see it increasing? Yeah. Because the red line is increased higher than the blue line there. Does that make
Okay,
It was just to get you all to think about resistance and how resistance will change. And remember, it was a non-test question because I want you to go over these, you know, a lot of these aspects, like when you go over it in lecture, it's like, okay, that's a really cool concept, but how do I apply this to the real world scenario? And so when you've got someone coming into your clinic and they are hyperventilating, right? They're hyperventilating. Maybe they're taking really quick, slow, shallow breaths. And if they're hyperventilating that way, right, they might be in that earlier example where you had, they could be hypoxic even though their respiratory rate is double, right? Or maybe they're you know, really big, deep breaths and they're, you know, they can't, sorry, that wore me out there. They can't catch their breath, but even though they're like breathing in real deep, well, what's going to be happening? Well, the resistance to flow is increasing, right? Which is why you see that. But if they're ventilating off more, which you do you know how to calculate that, then they're going to have potentially, they're blowing off too much CO2, right? If they're not ventilating enough, if they're hyperventilating, but there's not enough alveolar ventilation, actual ventilation getting their gas exchange levels, then their total ventilation, or sorry, their alveolar ventilation could be decreased, which means even though they're hyperventilating, they could potentially be hypoxic. Does that make sense? And so all that was just to kind of help you all think through in a little bit more detail some of these concepts. It wasn't to, you know, purposefully like try to trick you all. It's to like, oh, how would an even increase in velocity affect resistance from the trachea to the fourth division and from the fourth division to the alveoli? And the
that
answer-
makes sense. Thank you.
All right, great. Okay, cool. All right, and then I think somebody else had a question.
I'm actually okay. I sent you an email
Okay.
earlier, so we can just talk about it that way
Yeah,
since it's
sure,
3:30.
Sure. Yeah.
Thank
So,
you.
what we'll do is we'll go ahead and call it. I'll stop the recording here. If anybody has any lingering questions, you can either stay on or you can email me. Sometimes it'll be easier for me to just like record a little video response. But if you have a question right now and you wanna talk about it, just stay on and you can ask it. Okay. All right. I'm gonna go ahead and end the recording. How it is.